I'm also going to set up my fluid pump. So first I'm going to need to gather all of my appropriate materials, including my fluid infusion pump, the fluids that are decided by the veterinarian, a fluid administration set, a macro drip set, and 1-inch tape with an extension set. I'm going to set up the fluids so that they can easily be connected to the patient's catheter and begin receiving fluids. So I'm going to first do this by removing the plastic from this fluid bag, and I'm going to label the bag with the patient, the date, the time, and the amount of mLs in the bag before starting. And then I'm going to attach my fluid administration set sterilely. I'm going to connect my extension set, and then I'm going to compress here and allow this to fill halfway. Once the fluid line is set up, I can open my clamp here and allow fluid to run through the line, getting rid of the excess air. And then I can take my line and I can turn on my fluid pump. I can set my PRI to 114 milliliters per hour and my volume to be administered at 57 mLs for 30 minutes. And then whenever ready, I can connect my fluid line to my patient's IV catheter, turn the fluid pump on, start. As the surgical assistant, or the GCN, I'm also going to set up the pre-surgical supplies. So I'm going to select a sterile spay pack for this procedure and place it in the surgical suite, and I'm going to place it on the empty Mayo stand. I'm going to open just the outer layer to make sure that I don't contaminate the sterile field. I'm also going to select a number 10 scalpel blade and open it surgically. Just peel the ends and drop it and toss it into the open sterile field without contacting anything to make sure I don't break sterility. And I'm also going to get the 2-aught PDS suture and open this the same way without touching anything and toss it into the sterile field. Also, I'm going to get sterile surgical drapes and I'm going to open this the same way, only the outer wrap, and then allow the surgical assistant, once scrubbed in, or the surgeon to open the sterile field. For the patient preparation and placing a saphenous catheter, first I'm going to go through the supplies and then go through the whole procedure, and then I will show you my makeshift way of placing the saphenous catheter in my fake Sally. So first you have to collect all of the necessary supplies for this catheter placement. So you're going to need clippers with a 40 blade to remove all of the hair on the lateral saphenous vein, and cotton soaked in alcohol and chlorhexidine for your scrub, and over the needle 20 gauge catheter, and also an additional 22 gauge catheter in case there is issues when placing the 20 gauge. You're also going to need an injection cap, tape, and saline flush. For the procedure of placing a saphenous catheter, first I'm going to tear off my pieces of tape and I'm going to notch them and tab the ends of them so they're easy to remove after. And I'm also going to have my chlorhexidine soaked scrub or gauze and my alcohol soaked gauze for doing my scrub of the proposed area over the saphenous vein right here. After I've clipped the appropriate area on the lateral saphenous vein with a 40 clipper blade and remove all of the hair, I am going to do my surgical scrub starting with the chlorhexidine gauze, and I'm going to use a target pattern where you want to start over the proposed injection site. So right here I'm going to say is my vein, so I'm going to start over the vein and I'm going to work in a circular pattern, always keeping the outside towards the outer edge, careful not to bring any contaminations into the area, and I'm going to go around until I am at the hairline, and then I'm going to do the same thing with alcohol, the rinsing agent, and I'm going to repeat this process 3 times or as many times as necessary until the leg is clean. Now I am ready to open my catheter, so I'm going to use an aseptic technique, and I'm going to make sure that the catheter will slide off of the stylet before having it in the vein, and I'm also going to remove the little injection plug at the end of the catheter. I'm going to open my package for my injection cap, and I'm going to have my restrainer use a claw, their hand as a claw to hold off the vessel, and then using my non-dominant hand, I'm going to put my thumb alongside of the vessel without touching it to contaminate the area and able to hold it taut so that the vein will not wiggle as much. And then I'm going to introduce the catheter at a 10 to 20 degree angle, starting low on the vein, and do a quick poke through with the bevel up on the catheter and insert it into the vessel. I'm going to check, and as soon as I get a flash of blood, I can advance, but if I do not immediately get my flash of blood, I'm going to redirect if I'm not in the vessel and advance both the catheter and the stylet in 1 or 2 millimeters, and then check the stylet again for the flash of blood. So now that I've got my flash of blood and I'm in the vessel, I can advance the catheter off of the stylet and all of the way up until the hub, and then I can remove my stylet and connect my injection cap. The restrainer can stop occluding the vessel, and then I'm going to hold the catheter steady while using dry gauze to clean up the excess blood that is on the leg, and then I'm going to tape in my catheter. Now that I have placed my makeshift catheter, I'm going to attempt to show you how I would tape it in. So starting with my small piece of tape here already notched and tabbed at the end, I'm going to take it underneath the hub of the catheter, holding onto the catheter. The tape is sticky side up, and I'm going to wrap this piece of tape around the patient's leg, making sure that I do not tape it too tight because it may occlude the patient's vessel, and if it's too loose, my catheter will easily fall out. And now I am going to take my next piece of tape, sticky side down. I'm going to also place it underneath the hub of the catheter, making sure not to cover the injection port. Wrap this around my patient's leg. Now my catheter has been securely taped in. I have another piece of tape here that I would use to tape my fluid line if I was attaching my fluids, but now I can take my saline flush and I'm going to inject it into the injection cap, checking the area for any swelling or blebbing that would indicate that our catheter is not in the vein, that it is potentially in the sub-Q space instead. Before inducing the patient, intubating, and attaching the patient to the anesthesia machine, when it is time to induce and intubate, you must have all of the appropriate supplies out and be ready from the beginning. So induction supplies needed include the correctly drawn up dosage for Sally, so 4.6 mLs of propofol, which I have my labeled syringe right here, and then it is labeled with the patient's name, the drug, the date, the concentration, and my initials because I drew it up, and it's also recorded in the class drug book. And then for my intubation supplies, I'm going to need ET tube sizes. So you typically get your ET tube size from the size of the nasal septum in the patient. You want the largest tube possible that will fit in the trachea without causing any trauma, and then get a half size smaller and a half size larger. So in Sally's case, I have chosen a 6.5, a 7, and a 7.5 millimeter tube. So I'm going to completely submerge these tubes in water and inflate the cuffs and observe if there's any bubbles that indicate that the tube or cuff is leaking. I'm also going to need gauze as a method of securing the tube after it's been placed, and either a water lubricant that can be helpful on the tip of the ET tube or can easily use water. I'm also going to need a cuff syringe to inflate the cuff and gauze to hold the tongue. You can also use a laryngoscope as a light source for easier visualization of the larynx, and it helps hold the tongue down as well. And then if necessary, you could always use a stylet, but because these are larger ET tubes, I do not think this is necessary. Now that we have all of our supplies ready, we can induce, intubate, and attach our patient to the anesthesia machine. So our patient Sally has already been pre-medicated, and after 20 minutes, a saphenous catheter was placed, and now we can induce our patient. So Inducing Sally with propofol intravenously. Sally's dose again was 4.6 mLs. We want to administer this drug IV through Sally's catheter slowly. We only want to give 1/4 to a half of the calculated dose in every 30 seconds and only administer this to effect. If you give it too slow, excitement could occur, but if you give it too fast, apnea is common. We also want to check the stage and plane of the patient and test their jaw tone. So we want our patient Sally to be in stage 3, plane 1 before we intubate. Prior to induction, the appropriate supplies were laid out for intubation. So for proper tube placement, I have to have knowledge of the anatomy. I have to be able to identify the vocal folds, the epiglottis, and the glottis. I also pre-measure the length of the ET tube so that I know how far the tube must be inserted. And also the patient must be in stage 3, plane 1 with absent laryngeal reflexes and swallow reflexes. For my procedure, we are going to pretend that my dog is able to lay in sternal recumbency because that's how they should be for this procedure. And then I'm going to have a restrainer that will hold open the mouth at the maxilla behind the canines and extend their neck and raise their head so that the head and neck are in a straight line. And then I'm going to go ahead and grasp the tongue with the gauze that I have out, and I'm going to fully extend the tongue out of the mouth into the side with my non-dominant hand. And then I'm going to position my overhead light so I can easily see the larynx, and I'm going to use my laryngoscope to visualize the glottis here between the vocal folds, and the epiglottis may be lying dorsally, so I may have to pull it down with the ET tube, and I may have to push the soft palate dorsally. Then I'm going to gently insert my ET tube past the vocal folds here, over the epiglottis, and through the glottis into the trachea. After my tube has been properly placed, I can use my roll gauze to secure the tube in place over the muzzle of Sally, and then I'm going to place my patient in lateral recumbency, and I'm going to use my syringe here, and I'm going to inflate my cuff until it has the pressure of a ripe grape. And then I'm going to make sure that my tube has been placed in the proper place. It's in the trachea rather than the esophagus. So I'm going to do this. One, I can palpate the trachea, and there should only be one tube. I can also check for fogging of the ET tube. I can feel for air movement at the end of the ET tube as the patient exhales, and the patient may cough during the placement, but it is not guaranteed. Also, you could check for movement of the rebreather bag. Immediately after intubation, I'm going to attach my patient to the anesthesia machine. I'm going to do this by first turning on my oxygen flow meter, and I'm going to attach my patient's ET tube to the connector of the breathing circuit. And then I will turn on my anesthesia vaporizer and select the appropriate percentage based on the stage and plane of my patient at this time, and then I will maintain my oxygen and anesthetic at 1.5, and at this time begin monitoring regular every 5 minutes for respirations and pulse, and every 15 minutes for the temperature. Now that our patient is stabilized under anesthesia and is in stage 3, plane 2, our GCN can begin prepping our patient for the surgery. For the patient, we're going to put her in dorsal recumbency because this is the position that she will be in during her procedure for the abdominal surgery. First, we are going to remove her hair, and this area should always be knee even and symmetrical because this is the client's perception of how well the surgery went. Clipping should be done using a 40 blade. We want to hold the clippers flat to the skin, and we always want to use our non-dominant hand to stretch the skin in order to avoid clipper burn. And we're going to clip from the patient's xiphoid process down to their pubis, and we want, depending on the size of our patient, we're going to have 1.5 to 2 widths of the clipper on each side. And after we have properly clipped our patient, we are going to vacuum all of the hair from the surgical site and the work area to prevent any contamination from the patient's hair.